complexity, some academic collaborators were brought in. So, Sarah Walker, who I'd not met before this, but then ended up sort of meeting online every day for 3 years while we tried to help steer this. So she'd initially brought in some earlier career researchers in her group, and then as this got on, we were like, look, we've got to free up the early career people so they're not getting mired in this. And she and I ended up doing an awful lot of the kind of just talking about confidence intervals, because it turns out that mathematical, bio, and social statistics are all in some ways very similar, but in other ways you have these, the social statisticians at ONS, they've got the sort of chops in R or Python or data wrangling, but they use the idea that you can just know how many households there are in Milton Keynes, or whereas biostatistics is never like that, right? It's true that they have some uncertainty in the number of households, but nowhere near the level of uncertainty that you'll ever have in an observational study. So just their view on confidence and other things is just very different, and that was a real learning experience, but something I think would bring into the GM ecosystem, that we've got different people. We've got people in government, people with social science background, mathematical background, biological background. They're all biomedical background. They're all slightly different, but can learn from each other, right? So the key quantity of interest that we're trying to get out was community prevalence, and that's why the government was prepared to commission a large study. When you ask funders, they normally hate swabbing people where you get negative swabs. So most swabs are negative if you try and remove bias. So the big problem is most of the flu or whatever we see because someone's got ill and gone to the doctor. So it's a measure of incidence to begin with, but also it's massively, the ability to see that person depends on their health-seeking behaviour. So before, people have tried doing bits of like symptom monitoring on phones and things, and the suspicion tends to be that yes, the hospitalisations follows the community peak, but there's a bit of a difference between the community and what's seen in primary and secondary care for infections, and that is actually true. So, I'm not going to show you the results because we've not finished it yet. We're finally, we're coming to a kind of better understanding of that, right? But we did see actually differences here. And so Kuhn there, who's one of the earlier career people I mentioned, did very early on write a load of really nice R code that worked this out. And so while it was representative, it wasn't perfectly representative. So what we did was something called MLP, multi-level regression and post-stratification, and so Kuhn gets the credit for implementing this, but the idea is that you're trying to work out what's the probability that you're positive given a load of things, and what you do is you obtain the probability that you're in the sample of people given those things, and then you use like Bayesian reasoning to work out what the probability is that just a person is positive, because we just want an overall community positivity. And then you can also break down by time, age, and so on. But the question is, what percentage of the population has active, detectable COVID now on a Tuesday, right? What's today, Thursday, right? That was the aim, because you don't get that information on Thursday, you get it a few days later. And so you may have seen, or may not, these kind of graphs where we were trying to just estimate, so here in Northern Ireland, about 4% of people have COVID at that point, right? That's a useful number for planning all sorts of things, like, you bring a load of people together, because you say you're allowed to go to nightclubs now, right? 4% of those people will have detectable COVID, right? Live virus. It's a live virus test. Right? And so this is a really nice, I think it's a nice example of where doing something a bit more mathematically sophisticated is very helpful, because often you also want to know, is it going up or down? Like Lorenzo was talking about, and that can be a bit subtle, and you don't always want to look at whether your mean is going up or down. You've got all these, so these are a load of possible trajectories, and we said actually some of them are going down, some are going up. So we were able to use this slightly more advanced method to say actually we've got a probability of 80% that it's going up as of the latest observation, rather than saying we think it's, on average it's going up, or you can say 60% of our trajectories are going up, so it's sort of 60% chance of it being increasing at the moment. Which actually I find policymakers can cope with, right? They can cope with a bit of uncertainty, and probably should be made to, right? They like lots of people, like particularly the inquiry, have been hopping up and down and expressing incredibly limited uncertainty, but anyone who's actually there, and normally the real answer is I don't know. Okay, so then I probably won't spend too long in this context on other technical things we did, but although it's a prevalence survey, you might want to look at incidents and go, well, so if you think about it, today's prevalence is yesterday's incidents times the probability you're still infected, plus 2 days ago's incidents times the probability that you're still positive 2 days after infection, plus 3 days ago incidents. Yes, that's the people who had it newly N days, some over N, the people who got it N days ago and are still detectable. And so mathematically this is called a convolution, and so the collaborators, Daniela and Josh at Cambridge, are looking at methods for deconvolving this, right, and just checking that the prevalence is consistent with the incidence that we might measure in a hospital or through case finding. So there's an example of how that data comes out. Then the genetics was really, I mean, for years we've had these sort of textbooks where you say, well, if something's fitter than something else, like if a pathogen's fitter than something else, you'll see these logistic curves where one pathogen goes up and the other goes down. And you just kind of perfectly saw this for the emergence of alpha and delta and these other waves, right? It was, so having said we're very uncertain, sometimes the theory that's been around for ages is right? And we understand that the alpha was fitter than the wild type virus and delta was fitter than alpha, and so you see this the strain replacement, estimating how big that was here. So these are all quite technical graphs. So a really good thing that, so this is again work to come with Katrina and her group. There was a lot of this like jumping at variance, and understandably so, but people might have forgotten, as well as alpha and delta, there was a beta and gamma, right, and they didn't take off here. And that random community sampling tells us they were really minority, really, really tiny fractions of the epidemic, like 1s and 2s in this big study. And that actually meant that almost all of the beta and gamma that was found was because the Public Health England teams running around and trying to trace were actually tracing incredibly effectively. And so they massively oversampled beta and gamma, and that's a feature, not a bug, of case detection, because we were quite reasonably worried about beta and gamma. They created terrible problems in South Africa and Brazil and other places where they were from. So I think actually a lot of this thing like, oh, was test and trace a waste of money, whatever. Well, one of the things we've got coming is, yes, it oversamples and is biased, but the aim of it isn't to do surveillance, right? It's to catch that, follow strains. So actually, I think we've got a nice story coming for PHE's effectiveness, right? Which came under quite a lot of scrutiny. And then this is a more technical point where when something sweeps, it's initially not very genetically diverse, and so it sweeps. You suddenly get this drop-off of genetic diversity, and then the genetic diversity kind of increases linearly because you've got this like molecular clock in the virus. So it increases until it sweeps again, and then you lose all the diversity because you've got a new thing that's come with only one genome, and then it starts exploring the genetic space. Then so this is kind of like classic evolutionary theory is seemingly something we understand reasonably well, at least in this context, which is always nice. So this was this divergence. Another way of doing this divergence plot, and then the kind of family tree of COVID variants works out in the study here quite well. So this is what we actually do a lot of locally, is this kind of household transmission studies. So in contrast to tracing data, this kind of study design I said where you have regular visits is a bit more complex and involves quite a lot of mathematical analysis to deal with that. It's kind of, it's different. So a lot of people say to me, how do you work out who the first case in each household is? People who'd like to work with this data. And anyone who wants to can. But I said, well, look, we didn't have a simple rule. You can't just come up with a rule because it's so common. You turn up at the household, you find a certain number of people positive, but no positivity either side. But the point is that by having a household design, you get this kind of accumulation of, because people infect each other, you get an accumulation of cases. So this is like how many households have this number of positives over a period of time. this is just one of the periods, I just picked one, a load of periods of time to do this analysis over, and what you see is it's more common for a household of size 5 to have 5 positives than 4, right, during this period of time. And that's because if you've got 4, you probably infect the last person, right? So it's very different from it's different from other processes, and that's what lets you infer that there's some transmission going on. Okay? And so then we put this through a big complicated mathematical model, which I won't show the equations for here, but you see things like people working in patient-facing roles were more likely to bring the infection into the household, and particularly that correlates with when the hospital burden is highest. So we kind of knew this, but we're seeing a lot of extra evidence that, of course, healthcare workers are at increased risk of exposure. But actually lower during the period of vaccination when they got the vaccine first, right? But again, suggests that priority for vaccination was quite appropriate because they're a group at so much higher risk. And then here we've got the kind of our children more likely to bring it in. Well, it depends on whether the schools are closed or not. So schools were I just realised, so this is the wrong version of this. That should all be shifted left a certain amount. Sorry, because you remember the schools weren't closed here. Right, sorry, I've not updated the plot here. But it turns out that the schools did transmit infection, and this is one of those annoying things to learn because no one wanted the schools to be shut. I mean, it's absolutely terrible from a health economic point of view and education and inequalities and all that. Shutting schools is one of the last things we should do, but the science is what it is, that when they're open, the children do transmit, they do infect each other, and they do go home and infect their parents. So I think this is just one of these actual wicked problems, really, where it's not for us as scientists to say what the right thing to do is, but it was one that a lot of the more thoughtful civil servants and politicians wrestled with. And then this is really, really a fiddly one, but it's sort of the within-household transmission also backs up the idea that alpha was fitter and then delta was fitter, right? So you see more of that clustering behaviour with the new variant that seems to be more infectious than with the old variant. Okay. And then basically towards the end it all starts getting messy, and that's because COVID is now, although it's still filling up hospitals, very complicated dynamics of lots of different strains and lots of people have already infected a bit and have had, probably everyone here has a different immune history with COVID, different patterns of vaccination and exposure to different strains, and so it becomes this very much more messy. I said that we had this initially very simple thing of the sweeps, and most people go, oh yes, I had COVID first during Delta, and now no one knows, right? You might have had your first one during Alpha or Delta, but you've had a certain number of Omicron infections, probably. Lots of people have, and the Omicron genetic landscape is very complex. So we're keeping this work going. Anyone who wants this data can have it, and it's big enough that you can say things specific to Manchester if you care about it, but you have to access it via this secure research service. So it's open and sort of free, but you have to go through quite a large procedure to access it. And actually that's quite reasonable. It's very, very confidential data. So everyone in the studies very strongly consented for all sorts of linkage. So actually you can link it to tests. We never got the linkage to NHS data. It was completely consented for data. NHS England said no, so I don't know why. That was above my grade. But it's at some point in theory someone could try and link this to NHS data, but it never happened. But it is linked to test and trace data, all sorts of other things. The people are very, they were fully consented at the start, but it's very, very sensitive because you could find out all sorts of things about the participants if you were to analyse it in an unethical way, which no one did, but it still has this safeguarding layer. And then ongoing things, there's all, because it was so big, there's all sorts of things we should be trying to learn over the years. Like, for example, it's kind of obvious that you're more likely to vaccinate if people in your household do, either because they influence you or you're all just that kind of household that you're pro the mainstream or not pro the mainstream messaging. And so these are from Joe Hilton, just like literally days ago, because we're still working on these data. But what you see is that pattern of clustering of vaccine status changes the herd immunity thresholds, so it changes how, and probably works in our favour. For some aspects, the real household structure works in our favour, some works against. So we're trying to work out what that might mean for thinking about herd immunity thresholds for other vaccine campaigns, the fact you're going to get this household clustering. So that's thanks, that's my kind of whistle-stop tour through that project. And thanks for your time.